Hi, my name is Vinicius Nina. I'm a cardiac surgeon from Brazil. And first of all, thanks ACTS and CTSNet and STS for this opportunity to talk about humanitarian medicine. I do humanitarian medicine, and I have the pleasure and the privilege to be here with two distinguished colleagues. I'm going to let them to introduce themselves and start talking about lessons we learn with humanitarian medicine. Please, Bill.
Hi, I'm Bill Novick. I'm a professor of surgery and international child health at the University of Tennessee, and I'm the medical director of the William Novick Global Cardiac Alliance.
And I'm Marcelo Cardarelli. I'm a pediatric cardiac surgeon at the Innova Health System in Fairfax, Virginia, and I collaborate with the Bill Novick Cardiac Alliance to travel around the world doing this.
Excellent. And one of my duties, I'm a member of the board of trustees for Cardiothoracic International. I also do traveling around the world and trying to do this kind of very nice and pleasant work we do as surgeons. So let's start with Bill. Bill, planning a mission. So how do you advise the local team in preparation for a mission?
So we generally ask the local team what their current level of infrastructure is, what sort of equipment they have, what the personnel are, and how far along are they in their particular field, whether it's adult cardiac surgery or pediatrics. As you know, we only do pediatrics. So we try and get a picture of the team before we actually make a trip. And our first trip usually is a site visit to wherever it may be, if it seems like a viable request. As you know, a number of times you receive requests that don't appear to be viable, but if it's viable, we will make a site visit. Typically, there are three of us, myself or a surgeon, our biomedical engineer, and then either the chief of our operating room or our head ICU nurse. We typically spend 2 to 3 days on site, try to meet everybody, and explain to them how the trip would be planned from our side, and then ask from them, what specifically are you looking to get out of this trip, aside from children being operated on, aside from training? Is there some specific area you want to focus on? So I think the better understanding on the front side before you ever actually bring the medical team, the surgical team in, by both sides, the visiting team and the local team, I think can lead to a far more successful mission than just, quote unquote, parachuting in somewhere and jetting out at the end. So we try and be comprehensive in our understanding of a program, and we try and reveal as much as we can about how we would run it.
Well, excellent. And regarding the surgical list, do you give any advice to the colleagues, to the local team, regarding what kind of cases they should select for very good mission? I mean, to be prosperous and.
Yeah, we try to do the selection together. There's always, particularly when it's a first-time trip, there's always a large collection of patients waiting for surgery. And normally in our first couple of missions, until we learn the system, we try to be very conservative and don't do anything too high risk. And then as we begin to collaborate and teach and learn, we can start relaxing those rules and allow to get the complexity to go up very, very slowly, but it's the only safe way to do it.
It's not unusual, and I'm sure you've encountered this, for you to arrive somewhere and they give you this list, and it consists of arterial switches, Ross's Fontanes, Rastellis,
Sure.
and maybe an ASD and a VSD. And I think all of us understand that there's a lot of excitement and the expert team is coming. But the local team really has to be, I think, educated about the fact that we didn't bring our institution with us. We didn't bring all of our safety nets with us. And once you can convince them that it's better to start, as Marcelo said, then the trips go pretty easy. Normally it takes a couple days. They're upset at the start because you're not doing that switch tomorrow. You're not doing that rest deli the next day. But after 2 or 3 days, once they see the complexity that's involved in pulling something off like this, even at the RACS 1 or 2 level, they usually fall into line.
Yep.
It's true, because sometimes they are under pressure to get some case resolved.
Yes.
And they want to share this pressure with us.
Exactly.
That's it's true. Yeah.
Exactly. I mean, it's not, there have been places that we've traveled to and they present this child and yeah, it's some complex defect. First trip. And, oh, by the way, his uncle is the brother of the Minister of Health, Oh, okay. Well, that doesn't decrease the risk.
Right.
That's right. Yeah, it's true. And sometimes you have to face this very challenging cases, and they are under pressure to get them resolved. It's not that simple. So, and in these trips, what kind of advice do you give to them regarding this particular case? To refer them elsewhere?
Yeah.
Wait for the next visit?
We do a lot of wait till the next visit. Especially in the first couple of trips. As Marcelo said, once they become involved in the process and the routine and the stress, quite frankly, of providing this service in their hospital, then I think they become more receptive to this. But our norm has been to try to, if it's possible, to delay that complex case till the next trip, or maybe even the trip after that. And if it's something emergent, we'll try and help them find a place to send the child. Have we done an arterial switch on the first trip somewhere? Yes, under duress, but yes. The place we want to refer to wouldn't take the baby. It happens occasionally, but it is not the norm for us. We really try and stick to fairly routine cases on the first trip or two.
And if I may add, it's very different whether we go to a country that does absolutely no cardiac surgery and we're just there to get started with a program that eventually is going to be self-sufficient, and the other is when you go to a place, they do heart surgery, they do adults, or they do the simple older congenital, and they just want to increase their complexity. That's more, that's easier to arrange because we bring, at least in our case, we bring an entire team, it's like 15 to 18 members. We have every specialist, and so we can handle it, providing that we have the setup. But when you're starting from scratch, that's when it's very, very stressful and very scary.
It's something that worries me because there's a different arena. So, but it's a good point, Marcelo. So how do you train the local surgeons? I mean, to move a step ahead.
Yeah, well, I mean, Bill has probably much more experience than myself, but I think you have to work with what you have, number one. Number two, we presented an abstract at the meeting in 2013, I believe, about the shortage of how many surgeons are lacking in the world. Congenital heart surgeons is over 3,000. So how you produce 3,000 surgeons in a short amount of time, because babies are dying every day. And I like to equate it, I always tell people, it's not different than the way that United States created pilots for the Second World War. It went from 1,900 in the whole country to 250,000 pilots on a 4-year period. And sometimes you sacrifice something. The amount of knowledge that you can transfer, this has to happen in 3-5 years. It's never going to be the same that it was invested in us. It took 10 years for you to be a surgeon, for you and for me. So there's going to be less, for example, intensive care management. We were very comfortable managing, and we still are, managing the patients post-op, and some of our colleagues from intensive care may be unhappy about that. But we were very comfortable in the ICU. We were very comfortable managing, the diagnosis, the cardiology, reading an echocardiogram. But that's not, they're going to become more operators. They need to be safe in the operating room. They need to be able to do their job, their part of the job. And we will take care of training the nurse manager and the intensivist and the anesthesiologist to complement that skill. And unfortunately, surgery, I think most people can practice surgery. At certain level, you have to have some skills. It's like a sport. You know, we all play tennis, but I would never be ranked in the first 6 million tennis player, right?
That's right. Yeah, it's true.
It's very difficult.
So another challenge is the young females, Bill. With most of these places we go, we have rheumatic heart disease and so very bad valves. And we need to offer something. Sometimes they are repairable, sometimes not.
Right.
And we need to do something. And in some places I've been for cultural and religious perspective, they are very concerned about tissue valve.
Right.
It's a
What
big
tissue
valve.
did it come from?
So yeah, and they push to use mechanical valves. So what's your thoughts about that?
Well, I'm sort of in the same, I think, solar system that you are. You know, we try very hard to repair every valve that we can repair. And sometimes we're actually left with a suboptimal, perhaps, or not totally adequate operation. And something that we think will allow the child to grow a bit. But young women, aortic valvular disease, I'm a big proponent of. You've tried to fix the aortic valve, you cannot do it, she gets a Ross. Now, you say, well, you got a conduit. Now you got to come back and replace the conduit. And I understand that. And I think that the way our program is actually structured, it is really unusual for us not to be in a place after 5 or 6 or 7 years. So we've replaced our own conduits. The mitral, I don't think you have a choice. I think you need to have a sit-down talk with the family. I think they need to understand that, number one, anticoagulating a very young girl, 6'5", 6'7", is not a simple job, especially in the places where we travel to. And, you know, we always try and reveal to them that, look, if we do put a mechanical valve in, the chances that your daughter in this country is going to have a successful pregnancy are really infinitesimally small. So I push really hard, really hard. And I do tell our Muslim parents that, you know, this is a, you know, derived from a pig. I guess we could probably come up with some way to use a Contegra, but I'm in the mitral
Not
position,
available,
but
right?
I haven't
Right.
quite figured that out yet. So if they demand a mechanical valve, then, you know, they don't see the light, they don't want a pig valve in their child, they're not concerned about a pregnancy, and this is what we want, then we'll put one in. But my goodness, the last mechanical valve I put in was probably 7 or 8 years ago. It's been a long time. And I always like to talk to them about growth, you know, because it doesn't matter whether it's mechanical or a biovalve. As the child grows, that valve's going to become too small, even with perfect anticoagulation. I mean, you can't put a 16 in the mitral position and expect a 16-year-old to be happy with it.
So, and Marcelo, regarding this patient to have to do anything about the valves or repair or replace the valve, how do you educate them, the local team, to keep following them up and in order to see these patients very frequently, so
Yeah.
cannot lose them and can have them under surveillance?
Yeah, I think we use the same that we apply for all the patients. You know, we don't fix, except for an ASDs and a PDA, we don't fix anything. We palliate, even in the ample sense of the word. So it's not different than following any of our conduits or any other operation. Our switches, they have to be followed. And in general, that's something we put lots of emphasis. And we encourage all the centers we go to participate in IQIC, the database for developing countries. And that kind of puts an extra push in the follow-up part of the equation.
Oh, it's a great.
Yeah, I think the IQIC has really been a really excellent instrument for having these individuals understand the need for follow-up. So we're really happy with that database.
Yeah, and to look at the results, 10 years later, 5 years later, and start producing their own research based on the local conditions, not in the conditions in America or in Europe, which are completely alien to.
Besides of the IQIC, do ask the local team to keep you updated in a certain way?
Yes, we do, actually. Even though we are the advocates for it, and even though we stimulate their application to IQIC, the way the rules are set up is, we're not informed of the results. So what we do is we ask them to send the quarterly or annual reports, and we have a designated within the foundation. We have one of our advanced nurse practitioners is really our designee for maintaining the database and reviewing the results from the IQICs that are sent to us. Not everybody remembers, and we have to sometimes push them a little bit, but we think it's really critical to have everybody enrolled, and we do follow them. The other thing that we do for follow-up is that when we make a return trip, we like to have every child that we operated on in the previous trip come back. Come back and get your echo.
For a follow-up visit?
For a follow-up visit.
Oh, excellent.
Yeah. We try and promote that so that, for us, that's part of the education that we need to shift over to the local team is that, look, you're not just a technician doing an operation that's going to last a lifetime. You're doing palliative work for the most part, and you have got to keep up with these patients. And when they see us doing that, we're saying, okay, where are the children we operated on the last trip? We'll start calling them today. Okay, that'd be a good idea, It's a good thing to do, and we all do it. We've done it for years, but I think that all the societies and associations now are basically going towards the fact that, well, hospital and 30-day mortality is no longer good enough. Now you need 1 year and 2 year, and we're trying to push that on all the people that we educate abroad.
Excellent. So I think one important issue for us working in humanitarian missions is put a team together.
Yes.
So what are your thoughts about that? So how do you recruit your people?
I've been doing this now for, 25 or 26 years.
Don't look at me.
Yeah. I actually put my first team together in 1993. So I'm now 25 and a half years into this. We initially started by bringing a team from the hospital that I was trained in from the University of Alabama. And what ended up happening after that is that those nurses or perfusionists or anesthesiologists that made the trip, well, they talked to their colleagues that may have been at another university or another hospital. So word of mouth was the initial one. Now, when we would post the trip schedule on the internet, and we would get, typically volunteer responses, and then we built a database of all of the volunteers as they came in. And now what we do is that we actually send out the roster, if you will, the schedule, and say, these are the spots that are empty, these are the positions that we need filled, is it possible? Sometimes Marcelo and I have to get on the phone and make a special call, a special request, because something's happened, somebody fell out. Oh, I know it's only 2 weeks' notice, but please. And we do make a lot of trips in a year. I mean, our average for the last 4 years is probably in the neighborhood of about 25 trips a year. So we're very consumptive on volunteers, and highly dependent upon them. I think getting your volunteers to participate on a regular basis is dependent upon the experience that they have on each trip. And so, we try and make the trip literally as smooth as possible for them in terms of their airline tickets, their accommodations, their visas, all of those things we manage through the office. And, you take some of the anxiety of the travel away from them. And we also have our logistics coordinator says in all her emails to the volunteers, any questions that you have, feel free to call me. And, if I don't have the answer, we'll find the person that does. So I think making the volunteers feel comfortable, and I think also rewarding them for, quite frankly, donating a significant amount of time, to helping children in third world countries. So we have a volunteer spotlight on our webpage and on our Facebook page, and we will put somebody new up there all the time. Same for our quarterly reports and our annual report. Get a volunteer, get spotlighted, if you'll allow that. Not gaslighted, but spotlighted. So I think you have to treat them well, and I think if you do, then you can build a good donor base of volunteers.
Excellent. And Marcelo, sorry, go ahead.
Yeah, I just wanted to add a couple of things. An exact number, because we did recently a paper and we had to calculate how many volunteers we had. In 2015, 378 volunteers came through the organization to travel with us. That's a significant amount of people to manage and to keep them happy so they keep coming the next trip. The one thing we do not do is we don't bring entire team from an entire institution, because we don't want to transfer the culture of that institution to the places where we're going. And, the camaraderie and the friendships you have to develop. You kind of are forced to learn new ways to do. People think that we go because we give things. Actually, we get things. We learn things.
A lot.
Whether it's how to do surgery, how to do this, how to do that. We learn a lot. And we want that to transpire to all the volunteers too.
So they'll try to make them up from different
We
places.
mix them from different centers.
We're thieves, actually. We steal bits and pieces that we like from other institutions. A couple of nurses come from, I don't know, Great Ormond Street or, from Boston Children's. They say, well, we're doing this there now. Oh, really? Well, we like that idea. I think that it's a little difficult sometimes, the first 2 or 3 days. But then I think, you've thrown all these people into this thing together. You've been careful to choose the staff that can handle this work. And I think all the people that actually do volunteer, this is a different kind of person than the usual routine, straightforward individual caring for heart patients at home. This takes a special person. And they usually adapt pretty quickly. Usually the second or third day, things have meshed, they're working together well, communicating well with each other, even though we have, not unusual to have 3 or 4 different countries of origin on our teams.
Oh yeah, we went to as high as having 18 members on a team, and there were like 12 nationalities.
Wow.
But there is a constant. The nurse educator is always one of our staff members. And the surgeons in general, if they're not staff members, like I'm a volunteer, but I've been volunteering for long enough that I'm basically one of the staff members. I'm paid. But it's people who know the rules and the routines and what we do, and they can keep the order within the chaos of a mission.
Yeah, it's true. So for those joining a mission for the first time, for those volunteers, what kind of advice do you give to them? Sometimes they are young or very anxious.
Yeah, to just, trust us. We know what we're doing. We have done it a bunch of times. Bill has done it many more times than I have. And we know how this is supposed to go. And there's a dedicated staff to attend to any of their questions, and it's very anxiety-provoking the first time. So.
Yeah.
Okay, excellent. So I think to close this very nice panel, very nice conversation here, I'm going to hear from you guys. In 2018, what are the challenges to keep the humanitarian work moving? First from you, Marcelo, then I give
I think the challenge is to convince the funding entities, whatever they are, that surgery, any surgery, pediatric cardiac surgery, but all the surgical specialties deserve as much funding as the infectious, contagious diseases in the developing world. And that's a hard concept to pass on. And it's very different to judge what you're doing, because when you cannot prevent a disease, you have to treat it, right? Well, these diseases are not preventable today.
Sure.
So they have to be treated. And the challenge is to explain to the donors that's what needs to be done.
Back to you, Bill.
Yeah, I think I'll take the donors a little bit further. I agree with Marcelo on every point that he made. I think one of the issues is that it is incumbent upon all of us that are actually doing this to get the larger international bodies to start to recognize that congenital heart disease is a major killer for infants, and that investing at the ministerial level in building pediatric cardiac programs is actually far more beneficial to the country than to just continue throwing your reals, dinars, dollars, euros out the door and sending kids all over the place. There's an educational component that nobody gets. Team is there, there's an educational component. There's a cultural component. The families don't have to leave. They're there, they feel much safer, they're in their own city maybe, certainly they're in their own country. There's also, I think, there is a component of public health that we're struggling with trying to figure out how to prove, and that is that when you go somewhere and you're repeating your visits there, you change the dynamics in that hospital, not just for cardiac surgery, but for everybody. Now the pharmacy's got to move. Now the blood bank's got to move. Now they've got to upgrade and make sure that the power system's working more favorably and more reliably. So I think it's really incumbent upon all of us, and I don't know if it's at a society level or if it's an individual level, but we need to convince the ministries that, you're losing children because of this, and if you invest in this, it's far better for you in the long run than throwing your money after an airplane.
Okay, thank you very much, Bill and Marcelo. And again, EACTS and CTSNet and STS for the opportunity for this very nice conversation about humanitarian medicine.
Very nice opportunity. Thank you.
My pleasure. My
Thank
pleasure.
you.
Thank you.